Dear Chairman, ladies and gentlemen, thanks very much to the organizing committee for the invitation. And so I have to entertain you at this time of the day with this difficult task, or to disappoint you, we'll see. So good luck to me. And these are my disclosures. So I'm going back to my title slide, and let's see if I can get rid of the unnecessary bit of these slides. And so prospect for mechanical support for the single ventricle. Now, prospect means possibility or likelihood of some future event occurring. And for future, we said over the next 10 years. Spot on. But it's very difficult to predict what's going to happen. Probably we can anticipate, or we should hope or expect something to happen within the next 10 years. And why we should have all these expectations? Because we actually know the burden of the problem. And we know that about 200 glands and 200 fontanes are done every year in UK. If I have a look of the NICOR data between 2015 and 2018, more than 1,000 between glands and fontanes have been made. And if you look at the grand scheme, the fontan operation has become the most common procedure performed worldwide for congenital heart disease after the age of 2 years. So it's not unreal to predict that the adult single ventricle population in UK will double within the next few years, as shown by this paper, in this paper by Louis Coates and Associates. In addition, if we consider adult congenital patients with heart failure, we know that 1 out of 4 has got risk of dying within a year after the first hospital admission for heart failure. And this risk of death increased to 1 in 3 within 3 years. If you're a child, and these are Freeman data, we know that from the time of the transplant assessment, if you got congenital heart disease, you got significant survival disadvantage to reach the heart transplant compared the non-congenital heart disease children. So I think there is a need for mechanical support in the single ventricle population. But we need to face some issues for sure, and these are only the clinical issue. We need to understand the mechanism of failure, the timing of failure, of course, because failure can happen at any stage of the single ventricle palliation. There are anatomical constraints that we have to face when we want to consider implanting VAD in congenital anatomy. And we need to consider the full package that the single ventricle population carries in terms of morbidity. And also we need to ask 3 questions among ourselves. Can we implant a VAD? Is the VAD run going to be durable? And there's going to be a good results with that implant? And sorry if I disappoint you, but there's no specific pump designed for mechanical support in single ventricle. When it's possible, the univentricular hearts are supported with VADs that are designed and marketed for the 2-ventricle heart disease. Of course, we've been using this pump in the past, and this is our experience in single ventricle with the Berlin Heart X-Core device, first stage and second stage palliation, very small cohort of patients. We can see that the median length of support was very short. Results, well, less than 50% survival to heart transplantation. I'm not happy with that. North American multi-center study, no better results there. Larger cohort, but median length of support again short, and survival to transplantation still less than 50%. So we can probably say that yes, it's feasible to implant this device, it's technically possible. The durability is quite occasional, and I would say the effectiveness is somehow debatable. It depends at this point of the day your globet is half empty or half full. This is an interesting approach to the matter. It comes from a group in Florida. They got hypoplastic left heart syndrome patients. They've decided to do a primary VAD implantation and a hybrid procedure. So ductal stent, bilateral PA band, and implantation of an X-Core pump. Why they've done that? Because they had patients with poor ventricular function and already severe tricuspid regurgitation, or patient with coronary fistula. So you might say, yeah, well, it's a right decision. We should not attempt any conventional surgical palliation for this patient. And they got some results. The implantation was feasible. Durability has been consistent, I have to say, because some of the patients have been supported even up to 5 months. But again, at the best, 50% survival to transplantation. We've been using the third generation devices, of course. Results have been better, but we can't ignore that the profile of this patient is completely different. We are now talking about big children, teenager, or young adults. So HVAD or HeartMate has been implanted, all successful in these case reports. But the common link between these cases is that the main reason for fontan failure was ventricular dysfunction. So these are good fontans with poor ventricular function. You got good opportunity to put a pushing device in, and they will do well. But these are the patients that we know from experience, they do well with primary transplantation as well. So if you are able to move them directly to transplant, is anyway a very good option. Unfortunately, we know that the mechanism of fontan failure is way more complicated, and that's given. It's not only the ventricular function, it's a weaving of more complex pathophysiological changes. And we also know that if you are in fontan failure, it doesn't really matter if you got a normal or abnormal ventricular function in terms of transplant-free survival, but if you got esophageal varices, splenomegaly, ascites, so you got a high VAS score, then your chances of survival are very limited because they reflect the degree of right heart failure. Can transplant be the solution for this patient? It's not always the solution, unfortunately. We know from our experience that patients with preserved ventricular function had also a higher degree of VAS score, reflecting higher degree of liver fibrosis, higher degree of right heart failure, and they didn't do well with the transplant and accounted for 2/3 of the overall post-fontan failing fontan heart transplant mortality. So we should stay away with the transplant from this patient. We need better solution for this patient, and probably we should need some mechanical support for this patient. This algorithm came from Roadfield, from Indianapolis, and they tried to create an algorithm to see when is appropriate to put a ventricular assist device in fontan failing patient, or we need what is called a cavopulmonary assist. And they've stated that, of course, if you got poor systolic ventricular function, you might get away with a VAD. If you got a restrictive fontan physiology, you should have a cavopulmonary assist, but unfortunately, it's never one or the other. It's never black or white. You might end needing a combination of both, so effectively a BiVAD support. It was in 2008 when Professor Pretre in Zurich implanted this type of VAD, and this is probably the almost unique clinical example of effective and durable subpulmonic mechanical support for the failing fontan circulation. So they basically implanted a Berlin heart, separating the pulmonary circulation from the venous return. There's quite a lot of surgical reconstruction, quite complex procedure. They put a Berlin heart. The patient did well, recovered from right side heart failure, has been supported for 13 months, and then has been discharged home and then been successfully heart transplanted. So I can say that there will be a large proportion of fontan patients that will develop fontan failure that would be largely non-ventricular function-related failure. And the ultimate therapy might be heart transplantation, but most of these patients are a very high-risk candidate, and we don't know if it's worth to allocate hearts to high-risk transplant candidates. We desperately need an effective mechanical support for the single ventricle physiology, ladies and gentlemen, because we have to try to reverse the fontan paradox. We need to make this patient better candidate for the ultimate treatment that would be heart transplantation. So some animal models have been done for mechanical circulatory support in the Fontan circulation. And this is the one of the most recent that I had the pleasure to be involved with, and is basically the Fontan cannula project by Berlinhardt. So Berlinhardt is trying to design a cannula that would facilitate the PRED procedure that I described before in a way that it would be easier surgically to separate the venous return from the pulmonary circulation and implant a Berlinhardt as a right side support. So the design of the cannula has gone through different modification. We had an initial prototype with a reservoir that has been abandoned to this wild shape cannula, and also the orientation of the inflow part of the cannula has been, the angulation has been changed in due course, and fluid dynamic studies has been done, and the most recent prototype has showed better hydrodynamic performance with less stagnation of the blood and recirculation of the blood inside the cannula. Of course, fitting test has also been done based on 3D reconstruction. And I'm going to fly through this slide because there's probably not much time, but the cannula is prepared on the bench with the graft extension, and this part of the procedure is done just because we need to do an animal implant at this point in time. And it's difficult to orientate through this picture for the non-surgical audience, but I can tell you the procedure is done via right thoracotomy on a sheep and without the need for a heart and lung machine. And if I go through, ultimately, a Berlinhardt ventricle will be implanted to the inflow cannula, the new cannula, and an outflow cannula connected to the PA. And this is the final result intraoperatively, and this is the position of the pump on the back of the sheep. And we can see that flow probe has been applied on the draining part of the Fontan cannula and on the outflow cannula to measure the cardiac output. And if it is now play, you can see this happy sheep back in the stable, and isn't like a normal sheep, apart of the fact that it's got a VAD on her back and is a bit more shaved because we needed to do the procedure. And I want to thank the Berlinhardt team and the Lowen Hospital that is the guesting hospital for these animal implants, and Newcastle and Badenhausen Hospital as partnerships. So at the moment there are 2 ships running with the VAD, and those are the first chronic models, so they will run for 30 days if they survive, and then there will be future results in the next coming weeks and months. And moving forward to another animal experiment, this is from the United States, and I think this is probably the closest one to potential clinical human application, because it actually uses equipment that we have available in most of the centers. So this group has basically created mechanical circulatory support for the Fontan using an Avalon cannula, that is the cannula used for VV ECMO support, in a Feli Fontan ship model that has been created with valved extracardiac conduit. And I'm going to show you what's the procedure that they did. Basically, they created a conduit and they put valves inside, one here and one up here. Of course, one is facing down, one is facing up. They left this gap of about 4 centimeters between the 2 valves, and then you can see there is an opening here. So this bit will be sutured to the IVC. This bit will be sutured to the IVC, and the side opening will be sutured to the PA. So basically, we have a valved extracardiac total cavopulmonary connection, and they could leave the patient on a total cavopulmonary, the sheep, on a total cavopulmonary connection for a while then they implanted the Avalon cannula into the TCPC, and they started the VAD using a Levitronics pump, so a commonly used ECMO pump, of course, without the oxygenator in this case. You can see a flow probe on the aorta to measure the cardiac output. So why this experiment is very peculiar? Because they got something that is never done before. So you can take measurement, hemodynamic measurement at the baseline, when the TCPC is established, and then when the VAD is on for a few hours, okay? And we can see blood pressure significantly dropping on the acute establishment of the TCPC, and then the blood pressure normalizing with the VAD on. Cardiac output significantly decreased on TCPC, and then normalized with the VAD on. CVP doubled at the time of the TCPC and then normalized with the VAD on. Even markers of tissue perfusion, the lactate, was up quite remarkably and then normalized towards the end of the cardiopulmonary support. Of course, these changes are acute. You establish acute Fontan physiology, and it's quite easy to think that if you put a proper support for the TCPC, then all the markers will normalize. It's difficult to predict if it's going to work on a chronic failing Fontan model, but is it not possible to apply to an animal? And there are a few new pumps that at the moment are just tested in mock simulator, so there hasn't been any animal application. And again, Rodfeld from Indianapolis have been working on a cardiopulmonary assist since more than a decade, and this is his most recent paper where he shows the most advanced prototype that he has created, that is basically a rotary blood pump that is contained into a housing and will be put at the crux of the ideal TCPC, and this is what it looks like with the inlet and outlet diameters, and that has been tested in a silicon mock of Fontan circulation. And this is the proposed diagram of the surgical implant, and this is how it works in the silicon mock, and you can see that the dye is spread over the pulmonary artery. It looks like something that is small enough you should add ideally at the time of your TCPC, and then you will switch on and off if you need to augment the flow or empower your TCPC a bit more. But of course, we're way behind that. And this is another prototype that has been created by the Zurich team, and is a 4-bladed impeller with some mechanical bearing and a rotor and an housing chamber. And the hydraulic performance of the pump has been tested in a mock circulation, again with 2 inlet and 2 outlet, simulating a TCPC. They've done a 3D reconstruction based on an 11-year-old TCPC to test the fitting, and size is probably about 4 by 4, and it's a bit questionable if it would fit with the big aorta behind here and with the rest of the heart and the airways, but then we have to see. They've done a lot of fluidodynamic study that have showed that flow augmentation through the TCPC is very effective at different speeds, 2 liters, 4 liters, 6 liters. And also there's no major area of recirculation within the pump or stagnation zones. And is a pump that apparently is low energy consumption and is a low heating dissipation. So everything looks promising, but we need more tests, and we're still way behind. So let me conclude, and I would say that yes, there is an emergent need for mechanical support for the single ventricle population, but unfortunately we are still way behind a feasible, durable, and effective application of these devices, basically because we don't have the right devices quite yet. So we need to advocate the investment in new and dedicated technology to overcome the failing physiology of the Fontan circulation. Thanks very much for your attention.
Do we have any questions from the floor? Just look around. Oh, good, I can see you now. Yes, one up here on the balcony.
What happened to that Archimedes screw VAD that, was it Steve Westerby was trying to invent for ages? Because surely that as an inline pump in the inferior limb of the cava pulmonary would be kind of, to me, the ideal bit of kit.
I think the major problem with most of the pump, and I assume also with that, is recirculation. So the rationale behind of doing a major procedure like Prof. Pratt did is because to avoid recirculation, you have to go back to normal anatomy, separating the venous return, so creating a new right atrium to be drained, basically, to give back to the pulmonary arteries. If you don't separate the venous return from the pulmonary circulation, you would have recirculation of the blood. I think people have tried also to put impella inside the Fontan conduit, but you will drain only on the IVC and then give it into the PAs, but you will have blood recirculation within the TCPC. So the reason why that experiment with the valve extracardiac conduit, to my knowledge, has worked well is because the two valves inside are actually avoiding recirculation of the blood, and that's why it's been effective, at least on an animal study.
So thank you everybody for staying.